Right, good morning, everyone. Thank you for joining us for pediatric grand rounds today. Our speaker is our very own third-year graduating resident, Dr. Isabella Palomo Caturla. She was born and raised in Madrid, Spain, attended medical school at Madrid at Universidad Rey Juan Carlos. She lives in Roanoke with her two dogs, Bryn and Buddy. During her time here, she served on the bioethics committee. She has a special interest in hospitalist medicine, serving the underserved population, especially within the Hispanic community. After graduation, she will be a pediatric hospitalist at Carilion, New River Valley in Christiansburg. Please join me in welcoming Dr. Isabella Palomo Caturla.
Good morning. So my topic today is pediatric healthcare across the world, Spain, Germany, and the United States. I don't have any financial disclosures, but this is what I would do with them if I had them. So the objectives today, we're gonna try to understand the concept of health systems, evaluate the structural components across the different models, compare system outcomes. Specifically, we're going to focus in pediatrics, and then we're going to analyze the disparities in outcomes and identify areas where we can make a difference. This picture is me and my best friend from medical school, Maria. She is now living in Germany, where she is doing her internal medicine residency. So that's kind of why Germany and Spain and then the United States, that's where I got the idea from. So the agenda, this is a little bit of where we're going to go through. We're going to go through what's a health system, what the different models are, the examples of them in Spain, Germany, and the US. We're going to talk about the factors within the system. We're going to talk wait times, access to care, patient satisfaction, physician compensation, and then outcomes per healthcare system, including infant mortality and childhood mortality, breastfeeding and parental leave, vaccination rates, and obesity. And then we'll have some CME questions. So to start, what is a healthcare system? Well, the World Health Organization defines it as all the activities whose primary purpose is to promote, restore, or maintain health. They have three goals: improving health, so increasing the health status and reducing health inequalities; enhancing responsiveness, so respect for the person and client orientation are two big goals within that; and then assuring fairness of financial contribution. This means that every household pays their fair share and everybody's protected from financial risks due to healthcare issues. So the World Health Organization has a building blocks framework for healthcare systems that includes 6 different building blocks. So we have service delivery, which is like the delivery of effective and safe, high quality interventions to people who need them, when they need them, where they need it, and wasting as little as possible when it comes to resources. We have the health workforce. You guys may be familiar with this, that would be us. So the WHO defines the attributes for World Health Workforce as responsive, fair, efficient, and achieving the best outcomes possible with the available resources. Then we have health system information. So those are systems that produce, analyze, disseminate, and use reliable information on health determinants, system performance, and status. So basically, all of the epidemiological data that we have and all of the studies that we do on outcomes and what comes into a health system. Then we have the access to medicines. That is always going to be a key one. So it's making sure that all health products are of quality, safety, efficacy, and cost effectiveness. So that means good access to medications and other healthcare devices for everybody, and making sure that they are available and used based on the scientific evidence, not going off of a TikTok, for example. Then we have financing. That is going to be a big part of this talk. The World Health Organization says that a good financing system raises adequate funds while ensuring people can use the services and are protected from financial catastrophe. And then we have the leadership and governance, so that means like all the people who take care of writing those policies, the effective oversight, so that would be maybe like the FDA in the United States, so making sure that what we're doing is safe for everybody, having appropriate regulations, again, FDA, and then incentives. And then there was a paper recently that spoke as of a seventh block to add to the WHO's 6 building blocks model, and that would be the people. Because a healthcare system is very nice, but who are we serving and why? And so the people are patients, everybody that is involved in the healthcare system from a customer, consumer perspective. So again, the World Health Organization defines a well-functioning health system as allowing any person, wherever they live, wherever their socioeconomic status is, to access good quality primary care services with referral whenever it's necessary to secondary and tertiary care without the risk of financial hardship. That is something that the World Health Organization emphasizes a lot. Without the risk of financial hardship or financial catastrophe, that is something that can be seen among the literature quite a bit. So there's like 4 main healthcare systems. We have the beverage system. It is the one we're going to be talking about in Spain. It's also, you can find it in the UK or in Cuba. The Bismarck model is in Germany, Japan, Switzerland. Then we have the national health system model, and that kind of combines the beverage and Bismarck, and it's going to be in Australia, Canada, Taiwan. And then we have the private insurance model, which is the US, and then a lot of low-income countries also have this model. So just a little bit of a historic background. The beverage system was established by Sir William Beveridge, a British economist and social reformer. He wrote in 1942 a report called Social Insurance and Allied Services, that is very in line with World War II and UK being part of the Allies. And it's always known as the Beveridge Report. So this is kind of like what started the NIH in the UK and this kind of model. The Bismarck model is named after Otto von Bismarck. He was a German chancellor who established the first social health insurance system in what is translated as Health Insurance Act. I'm not going to try to speak German right now. It's not going to work. So this was established in 1883, and it was a political response to the emerging workers' movement at the time. So this is kind of like the first model that came up in terms of like state being involved in healthcare and having some sort of guarantees for everybody. And then we talked about the national health insurance model. It kind of comes as a combination of both the Beveridge and Bismarck models. And then the private health insurance is the model we have here. And I thought it was very interesting because it originated during the Great Depression. At that time, a hospital in Dallas created a non-commercial plan to stabilize its finances. And that was kind of the foundation for all the nonprofit Blue Cross plans. So we see that these models have been around for a while. The oldest one is 1883, so that's over 100 years old. And then around the Great Depression and Second World Wars when the other ones have been established. So what are the main characteristics for these models? So we have the Beveridge has universal coverage, tax-based financing, and the government owns the healthcare delivery. Then for the Bismarck model, there is a principle of solidarity. People have to have insurance compulsory per the state, and it's self-governed. And we'll talk a little bit more about what that means. And then the national health system is kind of a mix of both. So it does have universal coverage. It has a single fund pooling, which means that there is like one fund that that different parts of like society or the government contribute to, but there is single payer purchasing. So like the people get to choose exactly what model they want, and they will pay a percentage according to that. And then we have the private insurance. We can kind of know this one the best around here. It has voluntary enrollment, risk-based pricing, collection and pooling of funds, purchase of services, market competition, and profit motive. So this is like the one model that is more geared towards profit versus the other ones that are more geared towards like population health. So that we're going to see pretty stark differences between them. So here's a little comparison. So for primary financing, beverage, so that would be Spain, the financing is basically taxes. A percentage of people's taxes every year goes into healthcare, and that is divided accordingly. The Bismarck model is a little bit of a mix. So they will have payroll taxes, meaning like the same way that we get some money taken out of our paycheck every month that goes to taxes. It would be like that. And then there are premiums. So what that means is mostly it's going to be paid by taxes, but then everybody is going to pay a premium according to their social status or what their socioeconomic level is and what they can contribute to. And then the private insurance, we know about voluntary premiums and out-of-pocket payage a lot of the time. So for coverage, it's universal in the beverage model. Everybody who lives in the country who's a legal resident has that coverage for everything. In the Bismarck, the workers and dependents have full coverage, and then there is a percentage of them, at least in Germany, and we'll talk about it in a little bit, who, even though there is no contribution by them, they have free healthcare. And then in the US, private insurance, it's going to vary based on the ability to pay and whatever the employer insurance is if they have it. For risk pooling, so we have a single national pool in the beverage model. We have multiple competing funds in the Bismarck model. So what that means is that we're going to have the funding of the taxes, but then there's a lot of non-governmental organizations that actually compete between themselves in order to provide the services. And then in the US private insurance model, multiple private pools, you just get to choose whatever you want or can afford. When it comes to the ownership of the provider in the beverage system is predominantly public. We talked about it, it's tax-based, so that's how it works. The Bismarck model is more of a mix of private and public, but it's a combination, and the private insurance is, as its name says, predominantly private. The government role in these systems, so in the beverage, because it's basically a government model, it does everything, it finances, it regulates, and provides the healthcare. The Bismarck model is a little more independent as to the government regulates the system and also mandates that everybody has a health insurance. And then the private insurance is private, so minimal intervention by the state. When it comes to equity, the highest is found in the beverage and the lowest in the private insurance, and it's the other way around when it comes to administrative costs. So we're going to talk a little bit more specifically about the countries that we're coming to today. So in case you're not familiar with the European map, Spain is this little light orange country, and then we see it divided here into the 17 different autonomous communities, and we'll talk about it in a second. So the financing is mostly national budget, 70 to 80%. The system is decentralized, meaning that every autonomous community has their own healthcare system. And so what happens is the central government will get the taxes and divided among the communities, and they will regulate their own healthcare. So 70 to 80% is from that national budget, and then 20 to 30% is from the regional resources in each area. The total healthcare spending is about 8.5% of the GDP, and this is data from 2010, so it might have changed since then. The coverage, 99.6% of the population gets all medical services except for some dental care. 17% of the population also holds private insurance. What that means in Spain, it's not a super expensive insurance plan. It's like maybe 200 to 300 euros a year. And what people use it for mostly is to have quicker access. One of the weak points of the public system in Spain is the wait list. And so when you want a surgery to happen faster, or if you want more of like yearly checkups or preventive visits with some screening for cancers, a lot of people will get their private insurance and have that done in private hospitals. Private hospitals still have a pretty high governmental regulation. And then, yeah, we talked about it, 17 autonomous regions. The care is structured in a primary care manner where PCPs are gatekeepers and they're the ones who refer patients to specialists or hospitals. People can't just go to a specialist by themselves unless you have a private insurance. And then in the hospitals, people also just go to the ED like here and get admitted from there. So Germany has the JKV system. So the financing, about 14 to 15% is wage-related income. So what we were talking about, the amount that is taken from people's paychecks every month goes in part to the healthcare system. And then it's split between employer and employee. So basically, your employer is kind of going to match however much you give from your paycheck. And then there is some tax subsidies that also supplement this. And so everything goes into a central relocation pool and is redistributed in sickness funds. For coverage, 87% of have statutory health. Statutory health insurance is what we were talking about, being a mandatory insurance for everybody in the workforce at least. And then 11% choose to have private insurance, and so they don't have to contribute to, they don't get the coverage from the tax fund. So that's the difference with the Spanish model, is that you can have your private insurance, but that doesn't take away from you also having full universal coverage by the public fund. In Germany, it's either or, and you get to choose. And then we kind of talked about the remainder of people have governmental schemes, and that means that non-earning dependents are insured free of charge. And then they also have this thing where police officers, firemen, those kinds of like jobs have their own kind of insurance. I don't know that doctors are included in that.
What about physicians?
Yeah, I think it's more like kind of like first responders, but we're not first because we're in the hospital. So
maybe you get treated in your own facility.
Exactly. And then the organization is more complex. There is 113 competing nonprofit self-governed sickness funds that provide coverage, and the services are purchased from private providers. So those funds is what I was talking about, like non-governmental organizations that will provide the services and kind of like compete between themselves. So there is a little bit of free market, but it's still within a pretty strict regulation. And then we come to the US. So it has a private insurance and sometimes a mixed model. So the financing, when we talk about things like Medicare, is 21.2% of the total health spending. Medicaid comes to 17.5%. Private insurance, 35.6%, and then out-of-pocket about 11%. It's very interesting when you look at the data that when you count the tax subsidies from employer-sponsored insurance and the government coverage, that adds up to 65% of the total health spending. So there's still a lot of like public money that goes into it, but it doesn't necessarily affect people having universal coverage. So Medicare has universal coverage for those over 65 years or permanently disabled. And in 2013, that was about 52 million people. Then we have things like Medicaid and CHIP. That's kind of like our wheelhouse in pediatrics, where a lot of what we see here is like a federal state partnership for low-income populations, and it covers about 50% of the kids in the US. And then the private insurance, kind of, we talked about it. A lot of the times it's employer sponsored, and 58% of non-elderly people have this, and we can also be individually purchased. So there is a very distinct kind of structure in this system compared to the two prior ones. There is not a single provider, not a single system that provides insurance for everybody. It's a lot of different pieces, and you kind of have to figure out where you fall. There are big variation by state, and the three major payers are governed by regulations and market dynamics. So the payers, we talked about, are Medicare, Medicaid, and then the private insurance. They all have their own rules. It can be federal level and as well as state level. It kind of changes a lot. This is kind of what the American health system is supposed to be like as a structure. So we have the healthcare services, and they come from the out-of-pocket payment or public, I would say mixed health insurance, being Medicaid, Medicare. And so that all comes into private insurance. And so that is regulated by the government in a bunch of ways. And then the private insurance kind of has the power. We know this, we have to deal with this every single day. So it says like who can sell the health insurance, who should be covered, what should be covered, how prices are set, and how the providers are paid. And the what should be covered is meant to be both a consumer and provider protection for these reasons here. I don't know that it always happens like that, but that is what the structure is meant to be like. So we know the building blocks. Let's see how they work. We're going to go into these tables in more details, so don't worry about all the colors. But the first big thing I want to talk about is access of and quality of care in the US versus other high-income countries. So these tables come from a paper in JAMA that was pretty recent, and it kind of compares high-income countries across the world. The yellow is going to be the US, and so in this one we have like overall health. So we have population highest in the US than in any other high-income country. Population over 65 years old, though, is the lowest. GDP per capita is pretty high, only behind Switzerland and Denmark. And then the area is pretty big, just slightly behind Canada. And then the poverty rate, also the highest. When it comes to health spending, we have the US at 17.8%, so it's the country that spends the most percentage of their GDP in healthcare. Then Germany would be in the 4th position. We don't have Spain in this graph. I think it should be around where France or Japan are, so we're a little behind. Then you have the public spending on health the public part. We have Germany here in number 4 still. The US is way back in number 7. Spain, I think, would be around France or Japan as well. And then the mean spending per capita. So the US is where most spending goes to healthcare. Germany is way back in number 7. And again, I think Spain would be around here, but I don't have that data right now. And then we have like a lot of healthcare divided between different areas, but overall, population with healthcare coverage, Spain would be up here 100%. Then you have Germany 99.8%, and then the US is way down with 90%. So we were talking about this a little bit. When it comes to wait times, Spain is the winner of our study countries. The wait to see a specialist being over 2 months is about 11%. This data is a little behind. This morning, I just woke up to a paper, so an article in the Spanish newspaper saying that wait times keep going up. They are higher and higher. There's like, I think 450,000 people who are waiting for surgery, and they've had to wait over 6 months. So this data is a little old, but we still win compared to the US, and then Germany is the best when it comes to wait times for specialists. You can pretty much see your provider either the same day or the day after, but Spain is also a little bit behind on that. And then what is the people's perception? Do you feel like you spend enough time with your regular physician? I was very surprised by seeing that Spain also wins and people feeling that they have enough time, because that has not been my experience when I studied medicine in Spain. So I'm happy to see that people are that satisfied. I think my experience was very different than that, but very similar to Germany and then the US, they feel like they don't. And that again collides with my personal experience, which again may be anecdotal, but I feel like we spend a lot more time with patients here than what we did in Spain. Barriers to access. So we have missed consultations due to cost that the US is going to win, because in Spain and Germany it's basically covered. And then population lacking basic health coverage, it's only a problem in the US. When it comes to avoidable hospitalizations, it was very interesting to me that Germany wins in this one, and they have over 200 hospitalization per 100,000 people, or per 100,000 hospitalizations that were avoidable. In Spain, it's only 41. The US is 190, so closer to Germany, but it's still not quite as stark. And then when it comes to asthma admissions, it's pretty astonishing that the US has triple what the other countries do. So probably has to do with what we were talking about, access to healthcare, to medications, and people being able to take their controller meds better. And then when it comes to system satisfaction, population reports that the system works well. Basically, Germany is where people are most happy with their healthcare system, followed by Spain, and then pretty low in the US with a 19%. Of note, in Spain, the satisfaction trend is declining, and that is more consistent with what my experience was when I was studying over there. So then we come to socioeconomic disparities. We know that this is always a concern. It's not only a concern in the US, but also in countries like Spain and Germany. We find that there is lower satisfaction in the lower income groups, who have limited education, who have chronic conditions, even though there's access to universal coverage. In the US, also the low-income adults, especially with acute problems, have harder time getting access to care. And then what about COVID? That's something that's happened pretty recently in our lifetime. I had just finished medical school when COVID hit, and so this is a very interesting also paper from JAMA saying among the worst legacies of the COVID-19 pandemic is the lingering mistrust of the medical and scientific establishment by large shares of the population. This I find to be true universally. I think it's more acute in the US, and that kind of correlates with the data. The trust levels plummeted in April 2020 from 71% to 40% in January of 2024. So it's like a 30% decline in trust. And this also comes with the politicization of public health that happened during COVID. This also happened in Spain. You can see that there was more moderate decline, but still pretty significant. And also what we were talking about, it being a decentralized system where every region gets a little bit of different coverages, has worsened since the pandemic, because people with chronic illnesses had different access to care based on that. In Germany, it's pretty stable. It declined a little bit in the spring of 2021, but people are happy in general over there. Okay, so let's talk about money. Physician compensation, does it look like depending on countries? So Spain would be the lowest one. The gross income, it says 60,000 euros. It's a little lower than that a lot of the times, but if we adjust it for cost of living in Spain, it looks like that. Germany is more like 90,000. That's the lowest end of the spectrum, and it would be equivalent to like 70,000 euros compared to the Spanish. And then the US, we have a wide variety of compensation for physicians, but we're going based on what it looks like for like general providers. So it would be $250,000, which adjusted for the cost of living in Spain and with the euro, it would be 167,000 euros a year. So it's a pretty stark difference as well. Okay, we've talked a lot about what healthcare systems are, how they work, what are the outcomes. So again, we find these different tables from that JMA paper I was mentioning. In this case, I was able to find specific data for Spain, and so we're going to go through the different bigger rows. So we have the determinants of health. So percentage of population that's most. Germany wins. No, actually, we do. Spain wins. 19 to 23% of people over 15 years old smoke daily. After that would be Germany, and then in the US it's the lowest with 11%. Alcohol consumption, and this would be in liters per capita in population over 15 years old. The Germans win. They have 11 liters per capita. The US gets 8.8, and then in Spain, even though people say that we drink a lot, it's only 4.7 to 5.7 liters. So that is interesting for me. And then obesity, we know we win over here. 70% of the population are obese or overweight after the age of 15. Then we would have Germany, 60%, and then Spain with 54 to 56. Most of it being overweight, but the trend is going up over there as well. If we start talking about life expectancy, the US in general is the last one, and Spain does pretty well in this. Spain is like among the top 5 countries when it comes to life expectancy in the world. So our life expectancy over there is 83 to 84 years old. In Germany is 80.7, in the US 78.8. If we adjust for health, then in the US we would have like 69 years, in Germany 71.3, and in Spain 72 to 73 years of life. When it comes to life expectancy for women over 40, then we would have 46 to 47 years after 40, so meaning we go to 86 to 87 years for women in Spain, 43.9 in Germany, and 42.6 in the US. And then when it comes to life expectancy for men over 40, that's always a little lower. So in Spain, it would be 40 to 42 years, in Germany, 39.4, and in the US, 38.7. And then when we talk more pediatrics, this is more of what interests us, right? Maternal and infant health. So maternal mortality per 100,000 births. The US leads the list with 26.4 deaths per 100,000 live births. Germany has 9. In Spain is about 3.5. When it comes to infant mortality deaths, 5.8 per 1,000 in the US, 3.3 in Germany, and 2.3 in Spain. Neonatal mortality deaths per 1,000 live births is 4 in the US. Germany was right around here, and I forget if it was like 2.2 or 2.4. I'm sorry, I covered it. And then Spain is 1.8. And then when we do neonatal mortality, excluding the deaths under 1,000 grams, it would be 8.1. It would be 1.6 in the US, 1.49 in Germany, and 1.44 in Spain. So also Spain here is kind of a leading country, top 3 of lowest neonatal mortality in the world. So now let's make it a little less overwhelming visually and talk about life expectancy and such outcomes in our selected countries. So like we said, in Spain, life expectancy is the highest, with its 83 years. That's 6 years more than in the US. When it comes to avoidable mortality trend, it's improving in Spain and Germany and worsening in the US. Healthcare access, there's about 10% of uninsured people in the United States. Efficiency of the system in Spain, it's high, Germany moderate, considered the lowest in the US. Also for equity, when it comes to spending, it's the other way around. Spain spends the least when compared to the US and Germany. And then the outcomes versus spending. The best would be in Spain, and that kind of matches that system efficiency, equity, and spending. In Spain, being the worst in the US. Same JAMA paperwork, same JAMA paper. We were talking here in mortality rate in children, infants under 1 year old. In the US, it was declining until 2020, and then it has increased a little bit, it has stayed up. And then the OECD 18 are those countries that the paper was looking at. So it's not including Spain, but all the other ones that we were looking at, and it has been declining since. When you go to mortality rate for children and 1 to 19 years old, again, it was declining until like 2019, 2020, and then it skyrocketed again for some reason. It's around 30%, and then it plateaued around 2021. Probably COVID had a lot to do with that. And then rate ratios among these children when it comes to mortality in the US, they came down and then came back up. So it kind of correlates with what we've been seeing up there. Okay, pediatric mortality, let's talk about it. We have the US versus the OECD 18 rate ratio. When it comes to infants under 1 year, the prematurity is always the biggest cause of death. And so it's higher, the rate ratio is 2.2, meaning that it's over double in the US compared to the other countries. So the leading driver of the US infant mortality is disadvantages when it comes to social determinants of health. And that is not very surprising. Then SIDS, that was very surprising to me. The US is 2.39 rate ratio compared to the other countries, meaning that in the US it's almost 2.4 times more probable for an infant to die from SIDS than it is in the other countries. Congenital anomalies, the death is a little higher in the US compared to the other countries, even though we have similar detection rates. I think it has to do also with social determinants of health. Respiratory infections, a little higher. We talked about asthma hospitalizations being higher here, so probably has something to do with that. But this is infants, so never mind. And then birth asphyxia and trauma. The US does actually better than other countries. I think I've told this story before, but when I was in medical school, 3rd year, we had a little baby died in her mom's arms. She was a day-old female, and mom was left alone to breastfeed her after like a 19-hour labor and suffocated the child because she fell asleep. So I think here possibly there is a little better vigilance in the nursery than what we have in other countries. I think that could be an explanation.
And more C-section and externalized delivery, I feel.
Mm-hmm. Yeah, and as we mentioned, like there's more C-sections and a little more control with that. Okay, and then if we move on to children and adolescents, to 1 to 19 years of age, we have like a rate ratio of 15.34 in the US compared to the rest of the world. That kind of comes to the fact that we don't have guns anywhere else. And so children here have access to them. US children are 15 times more likely to die by a firearm than anywhere else in a developed country. That is pretty scary. When it comes to motor vehicle accidents, it's a little higher here, 2.4 times more in the US than other countries. And then substance use and homicide are elevated compared to the OECD 18, but not super significantly. When it comes to homicide, it's 82 times higher due to gun death rates. Okay, so let's talk a little bit about pediatric care across the systems. We have Spain primary care model basically as a combined system. So both pediatricians and general practitioners take care of children. And it's funny because we only take care of them until 14 years old. When I was 14, I was moved to a family medicine doctor. In Germany, it's kind of similar. Pediatricians account for 40% of the workforce, and the ages are 0 to 18. And then when it comes to the US, we have the medical home model, and it's ages 0 to 21. AAP pushes until 26 for continuity. I think that is a very distinct characteristic of pediatric care in the US, is that we actually have the medical home where we have one pediatrician that takes care of the same kids all the time and kind of knows them. We have more comprehensive visits. They are more frequent than in other countries. So that is pretty unique to the US, and I think that is a good positive thing that we have here. The structure of well childs, we have integrated preventive services, both in Spain and Germany. They're way less frequent than what we have in the US, especially in the first 2 years of life. But in Spain, you usually do have a provider that sees you. In Germany, you don't necessarily do that. You just go to the doctor and somebody will take care of you. When it comes to vaccine coverage, this is a big topic in pediatrics. Spain has very high satisfaction when it comes to vaccines. 7.2 out of 10 people think that the program is adequate and covers what it should. The measles vaccine rate is anywhere between 84 to 97%, and HPV vaccine is coming up to 60 to 88% at age 15. Germany also has pretty high coverage, but in 2020 they had to establish a mandatory vaccine when it comes to measles because people were not wanting to get it as much. So now over there it's mandatory for everybody to be covered for measles. And then in the US, the MMR rate is about 91.6%, so like a little lower than in other countries, but still pretty good. 60% of kids are vaccinated for the flu. It's the lowest vaccine rate. Honestly, in Spain, children are not covered. We don't vaccinate children for the flu. Only adults over 65, I think, are covered for the flu, and healthcare workers. So if you want your kid to get the flu shot, then you have to pay for it. I think it's similar in Germany, but I don't have that specific data right now. And then when it comes to mental health services, we have the integrated behavioral health in the medical home model in the US. And so it's more, we screen a lot for kind of like mental health or neurodevelopmental issues. We have school-based services, which is also unique to here, but a lot of the children who have disorders that are treatable don't receive treatment, about 50%. When it comes to Europe, the availability is different. It depends on the region. But when it comes to Spain, it's very specific. Like if you live in Madrid, Barcelona, Sevilla, then you're probably better off than if you did live somewhere in the rural countryside in Galicia, for example. But what is interesting is that there is not a lot of pediatric specialists in mental health in Spain. It's more of like a general coverage. We don't have as much subspecialty training as we can find in the US. And then in Germany is similar. The neurodevelopmental disorders are the most common, and they come up to 81%. When I saw this, it reminded me of a meme I saw recently that says like, am I autistic or just German? Kind of compared. So anyway, parental leave. So let's talk a little bit of about this. In Spain, you have parental leave up to 16 weeks with 100% wage replacement, where in Germany, it's 14 weeks with 100% wage replacement. In the US, it's very variable, nothing federally, but it comes to like local insurances. The total paid parental leave is like 16 to 20 weeks in Spain. So that's up to 5 months. In Germany, it's combined. So it's going to be a combination between the parental and maternal leave, maternity leave, and so it can be up to over a year. So 14 to 58 weeks combined. So my friend Maria that I showed you earlier, she has the cutest almost 2-year-old toddler, and when she had him was her first year of residency, and she got to stop working a couple months before delivery because it wasn't considered safe for her to stay working, and then she had a full year of maternity leave, which was pretty nice. She was very happy about that. And then here, 6 to 27% of workers have some employer-provided paid leave, but it's not universal. When it comes to the wage replacement rate, 100% is going to be covered in Spain for those 16 weeks. In Germany, it's going to be 65 to 100%. And then in the US, it just depends on the state, the employer, the insurance that you have. The job protection that is going to be unpaid. So imagine that you're in Spain, you have your baby, it's been 20 weeks, you're not ready to part with them. So they're just going to keep your job. It's going to be protected for you. You're just not going to get paid for however much time you decide to be out for maternity or paternity. In Germany, it's similar to that. And then we have 12 weeks of FMLA in the US, but only 56 to 60% of people are eligible. Paternity weeks, we kind of talked about it. In Spain, they also get 16 weeks for all fathers. In Germany, it's a use or lose 2 months, so 8 weeks, and then none in the US at a federal level. And then the coverage, we kind of talked about it. It's universal in Europe, and 6 to 27% of the workforce in the US has it. Okay, let's talk breastfeeding. It kind of, and I think I introduced the leave before I talk about breastfeeding because it has a huge influence into how much our infants are going to be able to breastfeed. So when it comes to Spain, 77% of people or moms said that they have ever breastfed. In Germany, it's much higher. This also comes to like the government's effort to have all children breastfed. My friend Maria had a lot of trouble with breastfeeding, but she would not be allowed to, like, the government wouldn't pay for her formula, or she didn't have like any access to anything other than breast milk. So that's kind of like how they ensure breastfeeding, kind of like collides with the fed is best thought that we have here. And in the US, about 84% of people have breastfed at some point. When it comes to the 6 months, it's lower in Spain. Breast exclusive or any breastfeeding at the age of 6 months is 38 to 47% in Spain. It's higher in Germany. Again, we talked about it. And in the US, it's still pretty high. I think 56.7% is very good data. Exclusive breastfeeding at 6 months, we come way down. Still winning with Germany up to 39%, and then the US has 25.8%, so that's pretty good. Any breastfeeding at 12 months. The US is leading here with 35%. And then formula supplementation in the first 48 hours and not breastfeeding as long as intended. We don't really have a lot of data for Spain and Germany, but in the US, we have formula at 19% of infants by the age of 48 hours and not breastfeeding as long as intended for 60%. And I think that kind of comes to maternal leave. So let's talk vaccines. I found this image and I thought it was very interesting. It's from an anti-vax publication titled Do Not Vaccinate in 1892. So this is not a new thing. Anti-vaxxers have been around for a long time. So when we compare, so DTaP in Spain, 95 to 97, 93 to 97 in Germany, only 93% in the US. And the trend is kind of similar, like MMR 91.6% in the US. Germany wins with 97%, and I think that has to do with their mandatory measles vaccination. Polio is pretty good, even in the US 93.4, so that's not far off from the 95% in other countries. Germany has the lowest hepatitis B vaccination rate at 90%. And then rotavirus is always the lowest, but the US has the lowest rate. The flu, about 53% in the US, and it's declining. We don't have data for the other countries because we don't really vaccinate children in those countries for the flu. And Germany is the only country with vaccine mandates. All right. Let's talk childhood obesity. So this is another JAMA paper that was pretty interesting. If we look at the little color scheme here, as it warms up, people are more obese. So you have countries like Mexico here, which are around the 50%. The US is orange. And then when you go to Spain, it's yellow, and Germany is more purple. So I think childhood obesity, and I think of Uter from The Simpsons. So we have in Spain obesity, 8 to 12%, 5 to 6% in Germany, and 18.6 to 20% in the US. When you combine it with overweight in ages 2 to 13, you have 24 to 30% of children in Spain, 14 to 21 in the US, in Germany, and 35 to 40% in the US. The trend is decreasing in Spain. It's stable to decreasing in the in Germany, and stable to increasing in the US, unfortunately. And then in the European countries, you have more overweight than obesity, whereas in the US, you have more obesity. Spain belongs to what it's called the Mediterranean cluster, and it's higher ranking compared to the other countries in the EU. Germany pertains to Central Europe, so it's a little lower, and then the US is globally among the highest ranked in obesity. Okay, thank you for going through all of these tables with me. It was a lot. Hope your heads are not exploding yet. So at this point, I'm going to open up to questions. Or we can just go to CME questions and you can think.
I just have one question regarding the neonatal mortality rate, infant mortality rate, and maternal mortality rate. It's like the highest among the US, among all others, but I care about this entity. Why do you think we're ranked the highest? Is it population-wise?
Well, I would say population-wise, but then again, it's a percentage. So population really is going to be normalized. I think access to healthcare, good prenatal care, it's an issue because like once the baby is born, they're going to be covered, but pregnant moms not always are. Mm-hmm. And we also like what I saw here when I came in, and I don't know if for you it was similar, but I was very shocked about the amount of like maternal exposure to substances that I saw. I think in other countries maybe it's lower. Like there is more of like a social understanding of you shouldn't be doing these things while pregnant, and I think that may
maternal health, because I feel we're
maternal health I think is the biggest thing.
And you have postnatal care.
Yeah, but it's very variable around the country. So the infant mortality rate in, let's say, Massachusetts is 1/3 the national average. It's 3 times the national average in Mississippi.
Yeah.
So that comes back to disparities and access to care and prenatal care and things like that. So it's very variable within the United States and within different demographic groups.
And even within a state, like when Dylan did his presentation on like Southwest Virginia health, like I was very surprised as to when it compared to Northern Virginia to our region. So I think you see that a lot in the US. So it's a country of highs and lows.
Yeah, it does make sense. Thank you.
I think what's really interesting too is we're shutting down even more like OBGYN and labor delivery. Like Martinsville has to come here to deliver now. And the other thing is Japan actually had more low birth weights than we did, like by percentage point, but they had the best or like the lowest infant mortality rate, like they were 0.9.
Yeah.
And so obviously they're doing something that we're not.
I see the wheels turning in your head, Dr.
I was
Thomas?
thinking that gestational diabetes is probably
Yeah,
higher
Yeah,
in our
probably,
population than comparatively to Japan.
Dr. Gideon?
Can I actually ask Dr. Tomez, were you surprised that the US's rate of asthma is so much worse than Germany and Spain?
It's not something I've studied comparative nationally, but, and so I don't have any insight into that, but yeah, it is shocking. Is it because of access to medications, access to, hospitalizations for asthma? In the United States, if they're higher, I can't think of any single factor except that we have a complicated access system.
Yeah, well, even when I came here and we had to figure out like the whole Flovent patent was an issue at that point. It expired, and so we had to change all of these children to a different controller. And then you have people who like get out, like they change insurances, and so they're not covered for that same inhaler. And it's so complicated, whereas you go to Europe and it's the same insurance and it's going to cover for the same inhaler. Like it's not going to be an issue. I don't know. That's just my thought. I haven't deep dived into the asthma, but I thought that was very interesting because the asthma rates globally is pretty much the same, but why is the hospitalizations so much higher here? All right, so I have a couple of AI-generated questions because we're not gonna find a lot of questions about this anywhere. So a physician is comparing healthcare systems across different countries. She learns that country A has a health system funded primarily through general taxation with one national risk pool and publicly provided services available to all citizens. Country B has a health system funded through household premiums and payroll taxes with multiple risk pools and services purchased largely from private providers. Which of the following best describes these two healthcare system models? So country A, Bismarck model, country B, Beveridge model, country A, Beveridge model, country B, Bismarck model, country A, NHI model, country B, private insurance, country A, social health insurance, country B, national health insurance, and E, both countries use the same hybrid model.
So B.
So the answer is B. The Beveridge model is in the UK with the National Health Service, and it relies on general taxes, one national risk pool, and publicly provided services. The Bismarck model is exemplified by Germany's GKV, and is funded through household premiums and payroll taxes, and purchased largely from private providers. And then last one, a health policy analyst is reviewing data comparing the US health system to other high-income countries. She notes that the US has the highest healthcare spending per capita, but ranks poorly on access and quality metrics compared to peer nations. Which of the following characteristics distinguishes the US health system from other high-income countries? A, the US has regionally administered universal insurance program. B, the US has statutory mandatory health insurance system. C, the US is the only country with a voluntary private employer-based and individual health system. The US has a national healthcare system with automatic enrollment, and the US has the lowest percentage of private insurance as the primary form of coverage. Yay! Okay.
We can choose.
So, thank you so much. Thanks especially to Dr. Lagdier and Dr. Borowitz for helping me out with this presentation. This is Klaus, who was my dog in Spain. He's an American pit bull with a German name who lived in Spain and wasn't and then these are my references. I did use AI to go through them because there's a lot. Thank you so much for your